My journey started back in 2022. It's been an incredible journey. It's way bigger than they imagined. We got a lot of data from atomic bomb survivors.
Radiation oncologist Dr. Bobby Koneru is increasingly known for his work in benign radiotherapy treatments. Highlighted last year in Elector's Focus magazine, Bobby shared how he's transformed his practice into a really busy clinic, significantly increasing productivity, and crucially, often providing transformative pain relief for patients. Since then, his dedication has earned him a platform at ASTRO and a recent publication in the Red Journal. Unafraid of skepticism and uncrowded research opportunities, Bobby seems driven to discover where there's potential benefit to more patients and to add value to more communities. So join me as we explore low-dose radiotherapy for benign treatments, uncover the challenges and triumphs of Bobby's journey, and gain insights into the future of this potentially transformative treatment. Welcome to this episode of Spilling the RT. I'm your host, Emily Bassett. Bobby, in radiotherapy, because we're sort of used to dealing with cancer on the whole, there can be a bit of a perception that benign is fine. Do you think that's fair to say?
That's a great question, Emily. And I think that as a specialty, we haven't come up with the right or accurate terminology to describe this, because I think benign is a pretty outdated word that we're using relative to malignant or cancer. Right.
Yeah.
But really, these patients who have these benign conditions really are suffering and are in quite a bit of pain and in disability. So I think it is time to probably find a better word for it. But for the purposes of this podcast, I think we could use that word.
And what sort of percentage would you say in general radiotherapy treatments that are happening now are for benign conditions such as those that you just mentioned?
Yeah, great question. And I think the answer to that really depends on where you're looking, right? Because if you look at Germany, and if you look at the patterns of care study that Germany put out, almost 100% of radiation oncologists there treat some benign conditions. And one of the stats that I've encountered was that up to 30% of all radiation treatments in Germany are dedicated to the treatment of benign conditions. Now, there was a more recent Swiss patterns of care that came out and that showed that, roughly around maybe 70 to 75% of radiation oncologists do treat some benign conditions.
Yeah.
But the frequency is much lower, maybe closer to 5 to 10%. And I would bet that, in the United States, we're probably around that number, closer to 5 to 10%. So to answer your question, I do think that it is significantly underutilized, radiation therapy, for the treatment of benign conditions. Dr. Samir Kiole, who's the current president of ASTRO, has kind of put this on the radar and has goals for ASTRO as a specialty to increase the utilization in the United States significantly from what we're currently doing. And I think it's great that our next ASTRO meeting that's coming up later this year, the treatment of benign conditions is a major focus of that.
And so you mentioned in the US up to about 10% of work is benign. How does the amount of benign patients that you see compare to that?
Yeah, and the 5 to 10% really is a guess, because we don't really have a national registry or patterns of care study that has come out. But that's just my guess based on what I'm seeing. But for me personally, about 20% of my clinic is dedicated to the treatment of benign conditions.
And some would say that you're a little bit of a maverick in your work. Can you remember, though, a sort of moment when you sort of realised that there might be a space to explore new opportunities like this in radiotherapy?
Yeah, my journey started back in late 2022, and this is when there was a paper by Austin Dove that came out, and it was published in the Red Journal, and it was actually the most downloaded article in the Red Journal that year. But it was a review on the treatment of osteoarthritis, there's a lot of changes, obviously, as we know, in radiation oncology right now, with the introduction of several different systemic agents and immunotherapy, and the elimination of radiation for several tumor types, and then the rise of hypofractionation. It's obviously opened up space in our clinics, especially if you're in the private practice realm. So that happened in my clinic where I'm working. We had more time and we had more space on the machine. So when I came across this article, I was really intrigued. So I presented this to our administration, and they were interested in exploring this. So we ended up developing our own internal protocols, and we treated our first patient. The first patient was a prostate cancer patient, actually, who had arthritis of the hands. He was an artist. He could barely, grip his paintbrush anymore. And it was a big passion of his to draw. So we treated his hands, and by the sixth fraction, he was freely able to move his hand and open and close his fist, and he was able to grasp his paintbrush, and he said it was life-changing, because all the various pain medications he did before didn't work. So so that was a really cool experience for everyone involved. I actually posted that patient on the experience on LinkedIn. And it was our first patient. And I remember that post went viral. I mean, there were over 100,000 views and over 1,000 likes and comments, and it was from all over the world. And that's when I realized, I think that's when it hit me, that this is not just some local phenomenon. This is a worldwide resurgence of this of interest in the treatment of these conditions. And from that, it's been an incredible journey, because I ended up, through social media, meeting several really prominent radiation oncologists who are really pioneers in the space, like Heinrich Siegenschmidt, Richard Schaefer. And then I've been collaborating with several other prominent radiation oncologists, like Dr. Weissman and Mook and Dr. Rule, Lisa Delac. So there's just so many pioneers in this space from Europe that I was able to get connected to, and that's really what led me on this path.
That's really it's really fantastic to hear. I can completely understand why that first post went viral. Actually, my mum suffers from osteoarthritis in her hands, and she was never a professional, but she's quite a talented artist. Who's similar story, can't really paint and create anymore. She's had quite extensive surgery and joint replacements in her hand, and you can't help but wonder at some point along the grades of her arthritis, maybe there could have been another option for her. So I can completely see why it's captured a lot of people's imagination. Everyone's bound to know someone who suffers from osteoarthritis, I think, in some way. So, and you mentioned that you presented this to your team, and presumably they were pretty open to this work. But I think that it's fair to say there's a little bit of skepticism around anything that's new, new way of doing things in radiotherapy, because we're very set on the way that we build clinical evidence. But if you could tell people who are a little bit skeptical, maybe just one fact that you kind of wish everyone knew about benign radiotherapy, what could that be?
That's a great question. I would say that, so there's a couple of things I think I would want to say for anyone that is interested in getting into the space. Number one, it's way bigger than they imagine. When I flew out to Germany to visit Dr. Siegenschmidt's clinic, I was blown away by the volume of patients, and that's all he does in this one clinic, just treats benign. And that's a new concept for most radiation oncologists in the U.S. at least. There's not really many U.S. radiation oncologists that are only doing benign.
Yeah.
But I was blown away by that volume. So in the United States, for example, there's anywhere from 50 to 60 million people who are potentially suffering from osteoarthritis, tendinopathies like plantar fasciitis, bursitis, and if we were able to even treat and benefit 5% of those patients, I mean, that's still a massive number, right?
Mm.
So it's an enormous opportunity to help patients, and I think that that was something that was unexpected when I first started dabbling into the space. I think the other big thing that I think a lot of us will experience some form of resistance to is the fear of secondary cancer.
Yeah.
When you're treating patients with benign conditions, it's something that always comes up. Because when we think of radiation, we think of not only treating cancer, but also getting cancer, right? A lot of that experience or that fear has come up from a couple of different things, a lot of which are outdated. Number one, we get a lot of data from atomic bomb survivors, right? And for the type of radiation that was used for that was whole body radiation. It was gamma rays. It was large doses deposited suddenly all at once. So it's not really comparable to what we're doing here, where we're doing extremely low doses to peripheral joints and tendons, right? And also in the United States, part of the reason why we kind of went away from doing low dose radiation for a lot of these benign conditions is because we treated all types of benign conditions in children. Back in the mid-century, we treated kids with tuberculosis and acne, and we didn't understand radiobiology the way we do now, and we didn't have appropriate dosing protocols at that time, and that led to a lot of secondary cancers. So instead of, I think, looking at it more closely and refining our protocols, which is what the Europeans did, Eastern Europeans did, we just kind of threw it all out. And now we're kind of playing catch up, and we're coming back to it. And hopefully we'll look at it with fresh eyes and realize the significant value that it holds, and let go of some of the old belief systems that we have about it.
So speaking of old belief systems, I was going to ask you a bit about the history of low-dose radiotherapy, because there might be someone listening who is not very familiar with that as a sort of vehicle to treat these benign conditions. So I believe Germany's been doing the treatment for about 40 years, as I think you said, but can you tell us a bit about the history of low-dose radiotherapy itself?
Yeah, I mean, low-dose radiation therapy goes back over 100 years, and some of the very first patients treated with radiation were patients that had arthritis. And as we discovered that radiation can treat these types of conditions, it actually became quite commonplace to treat inflammatory conditions like arthritis with radiation in Europe and in the United States. As I mentioned, somewhere in the mid-century, like even maybe the 1960s, 70s, the U.S. started kind of putting that off to the side and focusing on oncology. And that was due to various reasons. Some of it, as I mentioned, was due to the fears of secondary malignancy. And also there were pharmacologic interventions that started coming up around that time. So it fell off in the U.S. around the 60s, 70s. But in Europe, it kept going. And, the Germans did an amazing job working together to develop guidelines through DEGRO. And they were very prolific in putting out papers and publishing their experience from all of that.
Low-dose radiation therapy for benign conditions. A benign condition, tumour or growth, is not cancerous, meaning it does not spread or invade nearby tissue. Often considered not dangerous or serious, benign conditions usually grow slowly and are generally harmless. However, they can still cause local issues if they grow large or are situated near blood vessels, the brain, nerves, or organs, sometimes leading to serious complications. Treatments with functional radiotherapy for benign conditions are a broad field, but you can currently use 3 dose categories: stereotactic or ablative doses, intermediate dose radiotherapy, and low dose radiation therapy. CNS conditions like trigeminal neuralgia and neuromas, and emerging indications like cardiac arrhythmias require higher ablative doses with stereotactic treatment precision. Hyperproliferative conditions such as Dupuytren's, Lederhosen, keloid scarring, and heterotropic ossification require more immediate doses of radiation, which aim to cause DNA damage, reduce tumour mass, and give pain relief. Giving low-dose radiation therapy for conditions such as osteoarthritis and tendinitis, with doses less than 1 gray per fraction, creates an anti-inflammatory effect, although not all the effects are currently understood. What is known is that there's several important things that happen. Low-dose radiation therapy creates a powerful anti-inflammatory effect, which has been demonstrated in several clinical trials, for example, for osteoarthritis. And it does this via a few mechanisms. It can reduce cytokines, as too many can cause excess inflammation. It can reprogram tissue-present immune cells known as macrophages to reduce inflammation rather than cause it. And it can stop white blood cells from entering the area. Low-dose radiation therapy also has some powerful actions for conditions like tendinopathies, which are a degenerative condition rather than an inflammatory condition. It can stabilise fibroblast activity to prevent enlargement of tissues and fibrosis, which is the thickening and scarring of connective tissue. It also works on neurogenesis to alter the way we perceive pain by working on the nerves in that area. And finally, in some of these conditions, neovascularization can occur, where more blood vessels form, which can also lead to pain. Benign radiotherapy has been happening for over 100 years, with varied history and usage around the world. Currently, compared to countries like Germany and Switzerland, the US and UK have lower adoption rates, suggesting significant room for growth globally. As clinical evidence of low-dose radiotherapy for pain relief and improved quality of life for patients with chronic, non-cancerous conditions builds, benefits must be carefully weighed against any radiogenic risks for each and every patient and indication for irradiation. Bobby, you may have already covered this, I think, with what you said, but what are some common misconceptions about low-dose radiotherapy that you would like to address or clarify?
Yeah, and I talked a little bit about it already, but I think it's worthwhile going into the secondary cancer risk a little bit more.
Okay.
Right, and because and the reason I want to do that is because one of the biggest challenges I've experienced while I've been doing all this is trying to convince my referring physicians that this is not the same as treating someone with heterotopic ossification or someone with sarcoma, right? We're using 1/10 the doses that we would use to treat cancer, and significantly lower doses than what we would use to treat even heterotopic ossification. So when we're using doses that low, the risk of a secondary cancer is negligible, right? And when we think of secondary cancer, there's a couple of things you want to factor in. Number one, the dose, total dose, and for this we're using very, very low doses. The field size, it matters. For example, if you're using a big radiation field versus a really small radiation field, and for most of these joints, we're using pretty small fields. Number three, where, like the location matters. For example, if I'm giving radiation to, in an area where there's bowel or bone marrow, that's going to be very different than if I'm giving radiation to a joint in the hand, right? The risk is very different. When you're treating radiation to areas where there's bone marrow or bowel or breast tissue, they're going to be more sensitive to potentially some malignant transformation, versus if I'm treating a distal joint, the risk of a secondary cancer is probably very low. Okay. And then finally, age. the young, if someone is really young, if a 10-year-old or 15-year-old or 20-year-old is getting radiation compared to someone who's 70, the risk of a 70-year-old is going to be much lower because, the time it takes for a secondary cancer to develop at these low doses and in these locations is probably 10 to 20 years, right? So all four of those things I think are very important. And when you factor all of that in to the treatments we're doing with low dose radiation therapy for distal joints and tendons, the risk is negligible. We would probably estimate that there's probably a 0.1% lifetime risk of getting a secondary cancer. And the most likely cancer you're going to get is a basal cell cancer, okay, which is obviously highly curable. If you were ever to get that risk is probably only slightly above baseline, which you can get basal cell cancers even if you never get radiation, right? The way I counsel my patients is that I tell them that the risk of getting a secondary cancer from low dose radiation therapy to any one of your peripheral distal joints is the same risk as getting a CT scan of the abdomen pelvis. And there was actually a nice review and paper written about that. So that's where I get that kind of phrase. But that's actually very helpful for patients when they kind of hear it that way.
Yeah, to quantify it.
And even my referring physicians, when I kind of phrase it that way, that's extremely helpful for them as well, so that they understand.
And I can't really imagine that anyone's ever kind of said no after you said that, but have you ever experienced patients who then don't want to go ahead with the treatment?
Usually I've never had a problem from a patient. It's more so the referring docs, educating them, and there's resistance initially, and I think oftentimes it's patients that go back to them after I've treated them, and they tell them, hey, I had a great response, and there was no side effects, and it was great. That's usually kind of what wins them over time. So it's a little bit of an unlearning on their part before they kind of have buy-in.
Since osteoarthritis is the most common condition treated with low-dose radiotherapy, let's spend some time on that. So 32 million people in the US alone with osteoarthritis, over 10 million in the UK. This morning I was looking up Sweden, and I found a paper saying 1 in 3 of those over 65 in Sweden now will get osteoarthritis. So along with diabetes, osteoarthritis is one of the fastest growing endemic diseases in the world. So why then is there some hesitancy for the widespread adoption of low-dose radiotherapy for osteoarthritis, do you think?
Great question. I think one of them. I think one obvious one is the fear of secondary cancers, like we already talked about. But I think beyond that, in 2019, there were 2 small Dutch randomized studies that came out, and one looked at the hands and one looked at knees, and there were randomized studies comparing low dose radiation therapy to the hands or the knees compared to sham radiotherapy. And both of those studies came back negative, showing that there was no benefit of low-dose radiation. Now, the issue with both of those studies was that, number one, they were very small studies, right? Each one of them only had 50 patients total, around 55 patients total. So only around 25 to 30 patients in each arm. So, you can't really make a very strong conclusion based on a study that small. But furthermore, a lot of those patients had really advanced disease. Okay, and one of the things that we're finding out as we do more and more of these studies is that low-dose radiation therapy actually is more effective when we catch the disease a little bit earlier in its course, right? So I think those 2 negative trials really soured the progress when it came to adopting this treatment. For quite a while, and fortunately though, since those 2 publications, there have been several other really important trials that have come out. One in particular, was a series of studies that have come out of Russia. Okay, and And this was also a randomized study where they looked at 300 patients, so a much bigger study than the one that came out from those Dutch studies. They looked at 300 patients, and they actually randomized them between receiving glucosamine and chondroitin versus glucosamine, chondroitin, and low-dose radiation therapy. And the beautiful thing about the study is that they followed these patients for 10 years, number one. Number two, they picked patients that were earlier in the course of their disease, which was also important. And they produced several different studies from this, several different papers from this. Number one was they looked at these patients at the 3-year mark, okay, and they found that they had significantly lower pain, significantly lower disability rates. They had much better quality of life overall, okay. And one of the most interesting papers that came out was they also looked at MRI changes. Okay, they looked at patients who, so they did MRIs before they started the study on both of these arms. And then they did MRIs at the 3-year mark. And they found that patients who had low-dose radiation therapy had significantly lower rates of progression. So the osteoarthritis progressed much slower in those patients that had low-dose radiation therapy compared to the arm that didn't, which is really interesting to me because, you know, pain can be somewhat subjective, but when you're looking at it on imaging, it's very objective, right? And then finally, they wrote a paper that had a 10-year follow-up, and they found that those patients who had low-dose radiation therapy had almost half the rates of knee replacement. Now that number was not significant because in the end there weren't enough patients to really look at who had surgery versus who didn't, but it was still very intriguing nonetheless. And you know, the question that it raises is that, you know, can low-dose radiation not only help with pain, but can it also potentially modify the course of the disease, right? So that's a very, very intriguing question. There's also a paper that recently came out of Iran that was also, again, a randomized study comparing low-dose radiation therapy to sham radiation for patients with osteoarthritis. They also did a better job in finding patients that were in the more moderate stage of disease instead of advanced. And that paper also found a significant benefit to low-dose radiation therapy. There were around 60 patients in that study. So again, more patients in that study than the Dutch studies. So I think this has given more confidence to the community, and you know, I think there's momentum building when it comes to evidence to show that there is some validity behind this treatment.
So why do you think there is a compelling argument to use low-dose radiotherapy for osteoarthritis?
You know, for me, I think, well, number one, now that I have a pretty significant personal experience, right? I've treated over, you know, in the last 2 years, I've treated over 250 osteoarthritis patients and probably 400 joints, which is still only a fraction of what some of my German colleagues have done. But, you know, I've seen some really dramatic results. And I actually even published my own experience here. But in my opinion, I think the more recent randomized studies that have come out of Iran and have come out of Russia, to me are compelling. And what it tells me is that if you pick the right patient group and you're using the right dosing and protocols, I think there is strong evidence to show that it does work and it does help.
What are some important questions that you think still need to be answered regarding low-dose radiotherapy for osteoarthritis?
Yeah, I think that, okay, so let's start with number one. I would say I still don't know if we understand what the right dosing, timing, and sequencing is. For example, in the Iran study, they treated patients every day, Monday through, you know, Friday. They treated patients, they gave them a total of 6 treatments, and they were sequential. So they gave them those doses every day. If you look at the DEGRO guidelines, they recommend doses twice, just 2 doses a week. You know, and in, you know, in my practice, I've been doing delivering treatments every other day. So is there a right type of sequencing and timing? I don't think we know the answer to that yet. I think we're fairly confident on which the dosing, and 0.5 gray in 6 fractions seems to be the optimal dose. But as far as how quickly can we deliver that, I think that still needs to be answered. The second one is patient selection. I think we're still trying to identify which patients are going to be optimal for this. What we do know is that patients with severe disease probably aren't going to respond as well. I think the Dutch studies have shown us that. The Russians have shown us that if you treat them early in their disease, maybe we can modify the course of their disease, because those patients were very early in the course of their disease, somewhere between 0 to 2, grade 0 to 2. The study from Iran shows us that grades 2 to 3 are more in the middle work. So I think future studies can, probably try to answer that question: which patients would be the best for this treatment. I think that'd be a really good question to ask. And I think another great one is, when we're looking at how effective a treatment is, we have to look at two things: not only the efficacy based on studies for that particular treatment, but what are the alternatives? What are the alternative treatments available, right? If you're looking at osteoarthritis, for example, most patients start on conservative management, and that works for a period of time. But oftentimes, for most of these patients, that eventually fails. And then they have to wait a long period of time before they're eligible for surgery, right? So they're left in this gap, this care gap, where there's really not great options. Usually what becomes standard of care in that gap are steroid injections. Okay, and there's ample evidence to show that steroid injections for osteoarthritis is not very good. I mean, compared to placebo, there really hasn't been shown any big difference, but we still give it. There's also evidence to show that steroid injections actually even accelerate the progression of osteoarthritis.
Really?
Okay, so yeah, there's several studies that show that on MRI. So we know that, even with this evidence to show that, the efficacy is not great, and in fact, it may accelerate progression, we're still giving steroid injections to most of our patients, right? The other alternatives could be viscosupplementation, or you putting in a gel, in between the joints to increase lubrication. That also has not been shown to be that much better than placebo. But unfortunately, they can lead to several different adverse events. It's not completely harmless because you're still injecting something. And finally, there's PRP. That is the other alternative, which has shown some benefit, but it's quite expensive, and it takes quite a while for that to work. So when you put LDRT in that mix, in my opinion, the evidence for LDRT is significantly better than these other alternative therapies, right? But I think a great study and a great question to answer is, let's do a comparative study. Let's do a study with LDRT versus steroid injections, or one of these injectables. And I think that would answer some questions as well.
Bobby, you mentioned earlier your recent publication in the Red Journal. Congratulations for that, by the way.
Thank you.
What made you decide to write that manuscript?
I think when I look back at the amount of publications that have come out over the last 40 years, almost all of them have come out of Germany. And the last paper that has come out of the U.S. was several decades ago. So really, we don't have a modern experience with low-dose radiation therapy in America. So I thought it was really important to validate this in the U.S. because the American population is different than the European population, the Asian population. We have different body habits, different lifestyles, different diets. So that was the reason, and unfortunately we didn't have extremely long-term follow-up on our paper, but it was important enough for me to publish what we had, just to validate that, look, it does work even in the American population using modern techniques.
And as a radiation oncologist, how do you see the future of benign radiotherapy evolving in the field of radiation oncology? Because listening to you, it's hard not to feel quite optimistic about it.
Yeah, I am optimistic. And I'm also part of an organization called the International Journal. It's an international organization of radiotherapy for benign conditions. It was started by Dr. Richard Schaefer and several other radiation oncologists from the world are on there. And we discuss all of the different emerging ways radiotherapy can treat benign conditions. And I think that we're really just on the cusp of using radiation for many more benign conditions as time goes on. I'm really, such as, for example, even Alzheimer's, and I think that the implications for the cardiac conditions that we're looking at, like ventricular tachycardia and arrhythmias, these are conditions that have such a huge volume and can be so can create so much disability. I think that if we do find that there is significant benefit to radiation, it just opens the door for so many more therapies and the ability to help patients. So I'm very optimistic that way.
That's great. And you mentioned earlier an example of a patient that was very close to my heart who was an artist. Do you have any other perspectives that you can share with us regarding low-dose radiotherapy for benign conditions?
Well, I think this is why I keep doing what I'm doing, because I've seen so many inspiring stories just like that. I have several golfers that come here now, and it's almost like maintenance for them. They'll come once a year just to get a booster because it lasts them the whole year, and they tell me that it's changed their life. So the word life changing, I've heard that so many times I can't even count now, and I think that's what I love about this. And obviously, I treat, and most of my patients are still cancer. And we get our wins from that, but it takes a long time to get a win from that, and so it's refreshing to be able to have some really, I want to say, quicker wins with this. It's really gratifying to see a patient right on their last day saying, like, "Oh my God, I feel so much better. I'm able to live my life now that I wasn't able to for years." When you hear things like that, it's very, very gratifying.
Yeah, I can imagine it is for the whole team. As a previous RTT and dosimetrist, I can imagine you don't always get that feedback from the patient. So yeah, I imagine that would be quite exciting for everyone in the team, actually.
Yeah.
So Bobby, you've remarked before that you learn from attitudes about SBRT that actually being skeptical shouldn't stop progress. But I feel like you're almost destined to trailblaze. Do you think that's a fair comment? And what motivates you to do something a bit more out the box, at least in the US?
Yeah, well, thank you for that. I don't know if I can call myself a trailblazer.
I would call you a trailblazer. Certified.
Thank you. I think I've been very blessed and lucky to get exposed to some incredible mentors that have made it much easier for me. In residency at Northwestern, for example, I had some incredible mentors, and that allowed me to kind of dive into stereotactic body radiation. And that was I think that was kind of my first, I want to say, dive into something unknown. I did it at a time when no one else was doing it. And I actually loved that. But I had mentors like Manesh Mehta and John Kalapirkal and Arjun Sehgal. He was one of the mentors for me at that time. And I loved being a thought leader and someone who was doing it before everybody else and seeing the impact it was making on the specialty and on our patients, right? I think that drives me. Similarly, in the benign space, as I mentioned, I was very fortunate to come across some incredible mentors like Siegen Schmidt and Schaefer, and even co-authoring papers with like Lisa DeLocke and Weissman and Rule and Mook. They've made it a lot easier for me to be able to take some risks and put myself out there and learn from that.
I would say that you have a bit of a talent for communication, which I find, as someone who works in communication, sometimes is an undervalued skill. So you mentioned your viral social media post, but would you say that communication is a passion of yours? I may have stumbled upon a podcast that was The Monk and the Hedonist, and that was, exploring longevity and resilience, which I think really fits in with your drive to expand low-dose radiotherapy options for patients.
Yeah, and thank you for bringing that up. That was a podcast we started during COVID when everyone was kind of locked inside, and my friend was a huge longevity passion for longevity, and she's actually a longevity physician, so she asked me to help her out for a little bit. But to answer your question about communication, I'll have a funny story for you. I was born in India, and I moved to the Chicago suburbs with my parents at the age of 3. And, my mom went to a Catholic school in India, so she thought, hey, maybe it would be a good idea for me to go to a religious school. So she put me into a Southern Baptist Christian school. And I started that at around the age of fourth grade. None of us really knew what that meant, but it was a very intense Christian school. And I just devoured it up. I read the Bible all on my own, by myself. It wasn't even homework. And I ended up converting my whole neighborhood. I would just go around to all my friends and talk about it.
I can believe it.
That eventually scared my parents, and they took me out of that school. But I think it comes naturally to me to be a little bit of an evangelist when it comes to something I believe in. I enjoy spreading the message on something that I believe in, and maybe I do have a little bit of a natural talent for that. But I think it comes from my early Christian school days.
I do think you've got a natural talent for it. And then I guess finally I wanted to ask you what's next. So, where do you see this particular space going, particular opportunities and maybe challenges of the space that you're in?
Yeah, this is such a great question. It's a question I like answering because I think that as the whole world starts to adopt this more and more, and I already am seeing this in the US, capacity is going to be an issue. For example, at Loyola, there's already a wait list of patients who want to get in to get treated for these conditions. Because cancer is not going down. There's going to be a lot of cancer that continues to, need treatment. But the sheer volume of these conditions of like OA and tendinopathies and bursitis cases, it's going to overwhelm the system, I think, if we're not ready for it. So that's one thing. I think, and this is where, Electa, Varian, Extral. I think there are all of these industry players are going to need to come up with solutions to help us as radiation oncologists to address that. We're going to have to develop more efficient workflows to be able to get these patients in. Number one. I think another challenge is just, when it comes to cancer care, for example, we're so conscious about the patient experience, right? We're very mindful of that. We want them to have a very peaceful, calming experience as they're going through their cancer journey. We're not really considering that right now when we're talking about treating benign conditions. And it's actually very disjointing when an osteoarthritis patient comes into a cancer department and they sit next to patients who have cancer when they're coming in for their hand arthritis. And I think that's also something that we're going to have to think through. How do we enhance their patient experience and alleviate their fears of cancer already from radiation,
Yeah.
So that's going to be a challenge. I think that's something we're going to need to figure out.
I think it's an interesting challenge. It's going to be about balance. And I think a lot from a communication point of view about radiotherapy is part of my job is to sort of help communicate around that in general, because there's still quite a lot of work that needs to be done around kind of people who don't know about radiotherapy. And I've always had a theory that the more kind of slightly more exciting or new areas with techniques like benign radiotherapy can actually help the sort of overall PR of radiotherapy. But it's that very delicate balance of getting it right, to your points earlier around refining how it's done, who it's done for. But I think, done right, it has such a huge opportunity to help the kind of perception of radiotherapy and open it up to a new group of people who don't have that association with cancer, which is important, I think. So, I think it's really exciting.
Totally agree with you. I know that there have been several prominent radiation oncologists that have even talked about maybe renaming our specialty from radiation oncology to radiation medicine. But I agree with you, though, that I think as we do more and more benign, I think if we position this right, it'll actually help our specialty not be viewed upon as, with such fear. It may actually help us from a PR perspective, as you said.
Yeah, it's super exciting, and I'm really grateful for your time today. I personally have learned quite a lot. You could probably tell from some of my questions and additional questions. But I'm sure hopefully there'll be a lot of people listening who learn a lot and start to think a bit more about this. And I know you're just starting your day over there and you've got a busy schedule, so I'm going to let you go. But I'm really grateful for your time, and it was really enjoyable. So thank you.
Thanks, Emily. It was a pleasure. Thank you.
Thank you. If you enjoyed today's episode, then don't forget to like and subscribe wherever it is on your screen, and tune in for the next episode.